Afternoon, everyone. So we have Dr. Hooman Sadri presenting. He is an associate professor and is also an andrologist who specializes in male reproductive medicine and directs the Male Fertility Research Program. He serves as medical director for the American Society of Andrology Board of Directors and is active in related societies. His expertise includes electroejaculation, vas reversal, and microsurgical testicular sperm extractions. His clinic is a national referral for Klinefelter syndrome, other genetic causes of hypogonadism, and spinal cord injury fertility. So let's give Dr. Hooman Sadri the stage.
Okay, good afternoon, and thanks for the nice introduction. Actually, I have a lot of slides, but I like to have an interactive talk. If you want to stop me anytime to ask any question, feel free to stop. I can manage the time and then speed up on others. If you don't want to wait, or it's something, it's in your mind, just go ahead and ask the question. I have a disclosure about my organoid system patent, which I mentioned this morning too. That's the only thing. I don't have any financial really interest on this, but I have to disclose it. The talk actually will focus on infertility in general, about some definition, and also general things. Then we focused on Klinefelter. And because I was asked in the past, we have some patients and family of XXX to talk about that, although it's not my direct specialty, but I'm a little bit knowledgeable on that, and I can at least direct, people to the right person and the right, path. And then we will talk about some, current and potential experimental treatment options for Klinefelter patients. I like this slide because a lot of people, they're not actually familiar with the word of andrology, which she just used it. Even physicians, they don't know what's andrology. I mean, everybody knows the gynecology, but andrology, it's equal to gynecology in general, and the name, of course, if you think about it, you understand what it is. For reproductive medicine, actually, we cannot separate this. We have to have them really together because it's very complicated reproduction. You have at least 2 persons involved. Sometimes 3 persons or more are involved. That's why I love the field of reproduction. Very complicated and beautiful field. For terminology, fertility means the ability to conceive. That's very, clear. And fecundity means to have the pregnancy, because you have to have the live birth, but not only the pregnancy. And infertility, based on the definition, we call somebody infertile if they have tried at least a year and they're not successful. However, the 1 year is not always a standard. If somebody knows already has or potentially have issues, should they start earlier? There's no reason to wait, for any approach for a year. But 1 year for general population is what we have to use and then approach. We have a primary infertility, means people that they never conceive. And we have a secondary infertility, which means there is a history that that person has a pregnancy or a child in other relationship, but not in the current one. How infertility is common? Actually, I ask you guys the question. Do you have any idea how common it is? If you want to give a number. I didn't hear. What did you say? 5%. 5%. Any other? 20%? Do we have any other opinion? 20% is quite close. I mean, 1 out of 6 couple, they're dealing with infertility. Why we don't know? It's very common because it's a taboo. A lot of people, they don't talk about it. Although I'm happy that the things are changing. I have a couple of patients actually that they have a TikTok, about their infertility issue and share with others. And they earn money too, but more important is actually they're talking about this to other people, and the people say, oh, there are more people like me. I mean, it's really, it's a lot of mental pressure on these people, but it's quite common, and of course, the level of issue could be different, very severe to minor, but it's quite common. Historically, and it doesn't matter where you live or which part of the world, people think that it's more related to the female, but actually we know that it's almost equal. I mean, and always you have to think about both male and female partner. And a lot of time, actually, we have a little bit of issue on each part. And it's quite, I put this kind of nice table from one of our andrology textbook. You see, it really could be a combination of issue and, very complicated, as you can see, is the different colors. And that's why, you have to really approach people always, as a team and a team of a specialist. I never actually approach a male, which is my area, without knowing about his partner, and it should be in the other way around too. That's actually the important things. For the reason to cause infertility, specifically on men, it could be something from the brain to the testicle. And, of course, depend on the person and the issue, it could be different. This is a nice table. It shows actually more in details the as you can see, the genetics is almost around 8% of this. However, you see another number called idiopathic, which means we don't know. I mean, we're silly. I mean, we don't know about those. I believe a lot of those is also genetics because, there's 200 genes in body. If one of them has a mutation, the patient has a fertility issue. But we're not talking about that. When we talk about the genetics, it's more well known. And what we do in a standard, we check the chromosome analysis or the PCR on Y chromosome, and then we detect. And of course, Klinefelter is one of those because it's related to the genetics. How do we actually start anybody, including a Klinefelter, if he's interested on fertility? The first, very, very first is just looking at the semen. What do we have in a semen, which is a semen analysis. Ideally, the semen analysis should be done in the right place. The right place means not a general lab that they do one sperm count once a week or once a month. It should be done in a place that they know what they're doing. I mean, usually an infertility, center or a lab is doing very often. Like we have some remote control labs, that they do it. The collection of the samples should be done around between 2 and 5, but ideally 2 to 3 days abstinence of ejaculation. The patient should understand to collect the samples carefully. The first part of the semen always has more sperm. If the patient loses the first part, which is not uncommon, actually, it's kind of an odd situation to put a semen in a cup. Then a lot of men, are not really comfortable to do it, especially if they go to a room we have in the lab or a clinic, then it's really important and they should actually reschedule and drop the sample another day. If it's abnormal, always we should repeat it because we should not, mark the patient with one semen analysis. I mean, the guideline report recommended at least 2 samples. And if it's, abnormal, we should do. And personally, even if it's normal, I repeat it. And there is a reason, which I show you later, why. World Health Organization, WHO, has a guideline which, every few years it's, updated. You can see here from 1980 until the most recent one was in 2021, that they actually look at the data and they put the numbers of the sperm and the number of motile sperm, everything, volume, everything, and that's actually the reference value we have. This is the graph that I want to show you and to tell you why, even on a normal sperm count, we need to have multiple. This is actually a study somebody did many years ago. One single person dropped every 2 weeks, the semen. You can see how actually the numbers go. Even you can see some days close to the zero. You see, this is a fluctuation we have in men. And that's why, even normal men, I look at the fluctuation. If one test is normal, another test should be done not tomorrow, a few weeks later, then we have kind of an idea about the change. And I had rarely patients comes with a zero sperm in the first one, and the second actually sample, it's normal. Then it's really important not to rely on one, but that's the first thing. For the female, because I'm going to talk a little bit, it's much more complicated. I've actually a slide, maybe I should add it. It's exactly the same things. Female reproduction is much more, complicated. If men goes to shop, go to the mall, to the one store, buy, and go home. But the women, they go all the way and then they go. And I'm actually on a women's side. I'm a good shopper. I'm not blaming the women. I enjoy shopping, but that's the difference. But this is the female, reproductive system that is much more complicated. But of course, it's beautiful system of, tubing connections, the gonads, everything that, make it much more complicated to find the issue too. The common cause that they can make, female fertility, similar to what I show you, it could be, inside the reproductive center or outside of that one, which is kind of categorized in this slide. Both, male and female, our focus is mainly here for genetics. And this is a nice table that, you can see a different, chromosomal abnormality that can, be detected. But my focus is on these three groups. Of course, the XXX, which I will talk at the end a little bit. And then, of course, the XXY and other variation that are quite, similar to XXY because we don't have much data, but we believe that they are very similar. And XYY, which is more common than the others, and you can see how they're common. This is a picture of a normal chromosome analysis, which we call it karyotype. You can see all chromosome, from 1 to 22, the somatic chromosome and the sex chromosome. Historically, this is something that I like to share with my patients, especially with younger patients. I say, okay, do you know about why you are here? And we talk about the Klinefelter. I say, do you know actually what's the name coming from? He was a doctor in Virginia, actually, and he found actually these patients, they feel much better because Klinefelter looks strange, but it's the family name of a very nice doctor. He put, his name. Initially, he actually described this patient as a hormonal issue patient, but then a couple of years later, they found that, this is not an endocrine issue. This is a genetic issue, cause endocrine issue. The prevalence, of course, and it's the most common sex chromosome disorder in men, and more important, it's the most common genetic cause male infertility. That's why, we have to know about this and know how to manage them. How it happens, it could be from the egg, it could be from the sperm, and even could be after embryo form. And there's no reason to figure out what was the reason. We're not blaming anybody. It just happens, the error. But technically, could happen, from any of those error, and usually it's not inherited. Although I had, one patient many years ago, I never could confirm it, and he said his father has Klinefelter, his brother has Klinefelter, and he had Klinefelter. The only thing I could confirm was he, and he never came back to my office because I was about to actually write a paper on that family. That could be quite interesting, but usually, it's not inherited. There is a different variation of this, but the classic is 47XXY. In my experience, there's no classic. All Klinefelters are different, which we are all different. That's what I believe is not only, the Klinefelter. There are a lot of epigenetic things we learned this morning about, the effect of couple, the parents on the patients. I believe actually environment can affect everything on this patient, and that's what I see. The testosterone, of course, in these patients, a lot of time they start producing testosterone in a normal way that we expect. And many of them for a while, actually, they go normally. That's why, personally, I'm not in a hurry to put them on testosterone. I'm not against of testosterone therapy because I'm probably the most, prescriber of testosterone in my institute. Although I'm a fertility doctor, which I think we need a lot to help a lot of people, but including this, I'm not actually, in a hurry to do it because a lot of them, we can watch them and then help them at the time that they need, depend on, what they need. This is a complicated graph I put here, but I want to just, kind of show it to you, summarize it. It's a very beautiful, graph to me from somebody we lost him, Dr. Nischlag, one of the pioneers in andrology in Germany. Unfortunately, he passed away a few years ago. But here, what you see in a blue box, actually, it's what we have in a normal 47XY people. And then we have actually the infertile 46XY patients versus the 47. Then 46 that you see here are infertile people. Then, of course, the pituitary gland, which is amazing how a small gland like a pea under the brain can do a lot of things, but and it's protected there. That I think it's in the right really place, protected, but produce two hormones that are quite key for male reproduction in this case, and specifically for a sperm. The FSH is quite important. And of course, testosterone, which usually a man has two testicles, is responsible to produce testosterone. And you can see that compare between, or normals, the Klinefelters, but when they pass the puberty, the hormones from the pituitary, which is the FSH and LH, goes high, and testosterone goes lower than, the normal people. But compared to the infertile male with the normal genetics, it's different, but it's not, completely different. And this is quite important because when we manage actually the Klinefelter patient, we really need to look at, these hormones, especially for the FSH, that it's really a key for us to keep the options for them for future fertility. The sperm production happens inside the testicle. Each testicle is a different, organ and contains around 400 to 600 very long tubes, which I call them like a 400 spaghetti together. And all this spaghetti connected in one place, which the sperm potentially produce inside these tubes, which we call them seminiferous tubules, and then they pull together in one area of the testis, which leave the testis, goes to the epididymis, and then finally, during ejaculation, to the vas. And what we have, in Klinefelters, when they are born, they have normal, sperm stem cells. The difference between boys and girls in general, I'm talking about the general population, is the boys, they never, are born with any sperm. But the girls, they were born with their eggs. And then the eggs goes through the development. For the they are born with a spermatogonial stem cell, which is a stem cell to produce the sperm after puberty. The Klinefelters, they have the same normal, spermatogonial stem cell at the time of the birth, but around the puberty, they start losing those. And after puberty, rarely they have, those stem cells, and sometimes nothing, which I believe almost everybody has a little bit, but it's difficult to detect it because you're not able to, remove the whole testis to look at it. But that actually goes down. And that's the key. That's what happened, and that's why, the Klinefelter, if they produce a sperm, they produce in some of these tubules, not all these spaghettis. And the key is to find those area, and use the sperm. When we approach these patients, one of the important things is, of course, the size of the testicle. This is the tools I use at the clinic to, and I'm sure my colleague, I'm sure they use it, when they examine the patients to have an idea about the size of the testicle. All the testicle size at the birth are very small, and usually we don't see much difference until the puberty normally, which is the same for Klinefelters. And for Klinefelters, the difference is they start growing to around, something around 8 to 10 cc, and then they stop. And that's the key. And today, we don't have any way to actually push it forward. But the good question, even those are small testicles of their area. And that's the good news. The puberty, it's a critical time. As I told you, that's the time that they start losing the sperm stem cells. And that's something that we are actually very careful how to manage these patients. A lot of them, they need testosterone treatments because it's really help on different aspects. I mean, tomorrow I'm talking about testosterone in general, and we just had a beautiful session, for pediatric testosterone that maybe some of you were there. But testosterone therapy is important, which we call it TRT. But the point is testosterone therapy is against fertility, and is if you give somebody free money, what he do? Stop working. If we give testosterone, the testicles stop working and usually don't produce any testosterone and eventually no sperm. That's the challenge we have. There are options for these patients. I mean, there are some other medication that sometimes helps, not much on, Klinefelters. I've seen my colleagues, they put in some of them like a clomiphene, HCG, but a lot of them actually it's not indicated for them just as one single medication. But the nasal testosterone was kind of, a revolution for this patient, I would say. That briefly I mentioned here, and I talk more on a testosterone section. This nasal testosterone, which came to the market a couple of years ago, has a very short half-life, and the patient needs to apply it, multiple times per day based on the FDA approval, 3 times a day to each nostril, and then press for 10 seconds. And if they're feeling bad after 30 minutes, they can clean actually with some water their nose because the leftover doesn't do anything other than bother them. And this, because testosterone in most of the people, we have to be very careful. Based on the limited data, more than 80% of the people, there's no change on FSH level. I remember I told you that's the key hormone for the sperm production. And when they look at the sperm count, there was no significant change on that one. And the conclusion is not shutting down the testicle. It actually adds to what testicle produce. That's why, it's the good things. It's the extra help and without, hurting. These are 2 papers that actually 2 reliable infertility center on a small cohort. They look at and they show that there's no negative effect on sperm production. However, I'm very, very careful if I start with somebody either, to have it, to watch their FSH level before and after, before it's too late because the sperm production is a cycle of 3 months, but 3 weeks after putting on the testosterone, we can actually check the FSH. If there's suppression, that means we will hurt in 3 months, the sperm production. Then we have to have plan B. But if not, then I continue. And for normal people, I document and I tell them I recommend to have a basic semen analysis from you before I start this. If you have a low sperm count, I don't recommend nasal. But if they have a normal sperm count, I recommend it. For Klinefelter is different because if I do the semen analysis or it's already done, I know that the semen most likely is 0. But that doesn't mean they're not producing a sperm. There are, but we don't want to even, suppress those, a small area on the testicle. I'll talk tomorrow more about the testosterone treatment. I think it will be between 10 and 11. And I will be happy to answer more questions about nasal and other type of nasal and other type of treatment. For fertility preservation on Klinefelters, this is kind of approach we have, depend on, age. And I mentioned earlier this morning that the consultation may start even on a very early stage that, we see the patients comes, they have an embryo, they have a pregnancy with a Klinefelter, and they talk about the future. And of course, I can help more about the fertility and reproductive part. But I have some idea. And the first thing I do, I say, do you want to have more information? You need AXYS. And I actually refer them to the AXYS and all these nice sources AXYS has, and they actually learn more about that. But based on the age, based on that the patients comes to us, we, of course, we have a different approach for them, which I'm going through that one. We start with, history, medical examination to have an idea about the level of the puberty of the patient and the size of the testicle. Usually, the Klinefelters with a little larger testicle, we have more hope to find a sperm, which is good. That's a good sign, but size not always matter. Still we're very hopeful we can help a lot of them. In my clinic, I have some tool that I'm not saying that if you don't have it in your area, you don't feel bad that, I'm missing a lot of things, but it's good to know. There's a special, ultrasound that I use, which many, many years, the GI people use it for checking the liver fibrosis, and we have the same type of fibrosis in Klinefelter testis, and I use that as kind of monitoring these patients, sometimes help me as one extra. Still, we don't have actually a standard. My group has a paper ready to submit that we kind of develop actually a reference value for the pediatrics because we didn't have it. There's some paper, but it's not really helpful, or data probably it's the most common one that we use it for pediatric in general, and then we can apply it for patients like Klinefelter, kind of, find the time that the things, and the changes happen on the testicle. For fertility preservation, depend on the age, we expect different things. Of course, before age of 12, the chance that they produce a sperm is much lower. Is really depend on the Tanner stage, which is from 1 to 5. And we know that if it's a Tanner 5, there is a chance that the boy started producing a sperm inside the testicle. That doesn't mean he has started ejaculating, or if in any way, we can detect the sperm. Actually, we can detect earlier the sperm in the morning urine probably on those boys than, ejaculation, which is hard to ask or actually not comfortable to ask on that age. But when you're older, the option will be more. We have option like, put the patients under, sedation, do the electroejaculation, but these are not something that we really recommend for all Klinefelter. We use it for some of the pediatric cancer patients. And also, we have a testis biopsy and that's what I'm going to talk, because often we get a question, my son need to do the sperm extraction or biopsy from testis before testosterone treatment start or something. And my, simple answer is no. We don't want to put him under something is, invasive now. We have options, but we have to know how to manage for future, and we have more options. For the adult Klinefelter patient, which is my main, practice to do the microscopic testicular sperm extraction, this is the highest level of testis biopsy using the surgical microscope to scan different area of the tubules, because we can actually distinguish the more wide tubule than the others that potentially we have a sperm there. And this is something that should be happen, at the same time of working with the lab. Is not something that randomly we give. I mean, some places they do, but that's not the right way. My actually setting is the operating room is part of the IVF center. There is a door between the operating room and the embryology lab. And we have a window to the embryology lab. I called our embryology lab an open kitchen, because the partner of the patient sit next to the window, can see what we are cooking. And she actually see all the process of the sperm. And we have a monitor. We show her when we find the sperm. That's all for all microscopic sperm extracting patients we have, including the Klinefelters. Klinefelter is a little different, because what I recommend for Klinefelters, and it's my main practice, because I know that we are expecting very small number of tubules have a sperm, and a sperm is quite in a low number there. And I believe that a sperm is a little more fragile than, non-Klinefelter patients. I recommend them that we actually prepare their IVF cycle together, not doing the sperm extraction first and then freeze the sample, although always we freeze as a backup, but we actually start the wife, female partner IVF cycle, and then, we are standby to do the surgery for the Klinefelters to extract the sperm, and at least give them a chance to have the first IVF cycle, fresh sperm, fresh egg. And then most likely and hopefully they don't need another cycle. And this is what we actually find with our microscope. We hope to find some area that the tools looks different to the others, and we get a very small samples, pass it to the lab, they start dissociating. This is around 3 hours process when the patient is sleeping under the sedation. And then we actually check different areas, and then we stop when we find and we have enough for the next step. The in vitro fertilization, which started over 30 years ago, IVF is the one that you just leave the moving sperm in a dish with the eggs, and they go to the eggs. But of course, a revolution, which we use it now as a standard treatment in most of the modern, center, is the ICSI or ICSI, intracytoplasmic sperm injection, which started with the Belgian group, in 1991. And we actually get one sperm, inject to the one egg. And that's the standard, which even we don't need a motile sperm, which usually the testis from sperm from the testis is not moving. Then you can use these techniques. For Klinefelter patients, there are many papers, from different groups. The most complete meta-analysis shows that overall there is 44% chance of finding a sperm on Klinefelter adult, regardless to have or not having testosterone treatment in the past to find their sperm. And then the overall live birth rate is around 43%, roughly 50% chance of finding a sperm and 50% chance of having. A lot of urological articles are not really nicely following the pregnancy of the patients and the embryo and different cycle of transfer. In a good, center, which you can actually compare the IVF centers by a website from across the street here, the CDC. CDC website has a page that you can actually go choose your state, your zip code and look at the IVF center around you and look at their success rate, in the different years, which is inspected and it's reported there. It's not mandatory for all centers, but the good center are part of this. And based on that data, a good center, the chance of having pregnancy after transferring one good quality embryo out of the IVF, it's 70%, which is quite good. If the partner is under 35, that means that we should recommend the Klinefelters not to postpone having a children too late and have a partner older, because the female factor will be added to this one and make it more difficult. But that doesn't mean that we're not able to help if their partner is older than 35. But the chance of pregnancy per embryo transfer will be less. But 70% per one embryo is quite good. And imagine that if we create multiple 10 eggs, 10 sperm, and 10 good sperm, which we can find usually through the surgery. And then if we have 5, embryo frozen from them, and each embryo has around 70% chance of pregnancy, the number is much better than what we see from the meta-analysis. I hope that makes sense. But that actually in the reality that, we have. We have some data actually that we are hoping to publish soon that we actually follow up better the pregnancy. Yes, please. It's mainly for them not to have it later because important. I got your question. You mean that is there a difference between, the chance of finding a sperm on a 30-year-old Klinefelter versus 40-year-old? I got your question. I would say no. However, if you look at the data, you see something. It was interesting, actually. I think a few years ago, we were in, I think, the ward, I think in Münster was a Klinefelter workshop, which we will have the next one this year. And somebody shows that at the age of 27, they had, or 28, they had the highest level of this. But when you look at the data was not really convincing. And I can tell you that there's no reason, because what happened on the testis already happens. Otherwise, the patient has some comorbidity, because if it's a Klinefelter and has a diabetes and the diabetes become worse and worse, that affects everything, including. But if it's otherwise healthy, the age of the male usually doesn't affect, but make it more, difficult, because the quality of the egg will be, lower after, age of 30, and especially after age of 35, and make the case more complicated. Good question. Sure. And for every embryo that we form on the Klinefelters, we recommend to do the pre-implantation genetic diagnosis. What does it mean? That means that at day 5 of growing the embryo, which few centers actually don't grow more than 3 days, but the standard right now is keeping the fertilized egg for 5 days, and when they create the blastocyst, which is a couple of hundred of cells, and then you freeze it and usually transfer for implantation in a normal, cycle. Some cases or some places they do the fresh transfer, but the standard we do is actually we do a laser biopsy, which is developed for this from the outside of the embryo, like a skin biopsy, without hurting the embryo, to get 1 or 2 cells. Then we freeze the embryo, and then we send that 2 cells to a third-party company to analyze for the, molecular karyotyping and tell us, about the aneuploidy, the chromosome abnormality. Then we know that every embryo has normal or abnormal karyotype, and of course we will know the gender. It's the female or male. We can actually reveal it or, keep it from the couples based on the request. And a lot of them, they say, okay, I want to go for the healthy embryo without regardless to the gender. But if they want to choose the gender, they can choose the gender too. And that increases actually even the chance of, the pregnancy happens sooner than later. Because even on an IVF ward, when we do multiple, embryo formation, not all the embryo are normal from normal people, normal chromosome people, then the chance you transfer abnormal to see the miscarriage and no implantation is quite high. Then it's increasing when you are transferring the normal embryo. Yes, ma'am. Very good question. Actually, I think the most beautiful paper out of this is not a very new paper, but it's probably 10 years ago, but we have more data, but very specific one recently we actually discussed with my fellows. It's a work was done from a group in Israel, and they actually look at the semen of the Klinefelter patients and the testis samples, and they did the fish analysis for the aneuploidy. And they show that there's, when the sperm formed, although the number is low, but the chance of having abnormal sperm is not significantly higher than the normal people, which is a good thing, which means the body corrected during the sperm production. Could I answer your question? Good. Okay, then this is what we have in our hands. I'm not advertising for my work. Actually, I'm proud of my teamwork because the IVF is a teamwork. Nobody can get, the single credit of success or, blame of unsuccessful, IVF. In our hand, when we offer the fresh microtesting, which sometimes, it's denied by patient because I'm not comfortable to do the fresh microtesting. Otherwise, the patient is open to have a backup donor sperm because I tell them that based on our data, I can guarantee 70% I can find your sperm. Although for Klinefelter, my number is higher, but I don't tell the patients and I don't warranty that one. The good thing is we can find even more than 70% for non-obstructive azoospermia patient, which is patients that they don't have any blockage, it's just a misproduction. Or overall data is 70% because of the system we have, because we have kind of a special sperm detection that we're actually publishing soon, or methods. And somebody say, why you're doing, because other people can do it. I said, we want to do it. We have enough patients. We want to actually pass this to other people to do it. We have a gradient system. We develop it in-house, and we actually put the samples, if we don't find initially a sperm, through the processing of that, like a gold mining, and then we actually have over 70% chance of finding the sperm overall. And we know that this is quite, viable. And as I told you, the chance of, pregnancy for younger is quite high, female partner is quite high. Yes, sir. Very good question. I mean, yes, the short answer is yes, but I am not in a rush to operate anybody. If I see the patient, otherwise we have a special situation, family situation, medical situation, losing, very soon the insurance coverage, this kind of things. Always I prepare, the patients for the surgery, which means if they have been on testosterone for a long term, we switch the treatment for at least 3 to 6 months. And then we do the surgery. We kind of turn on the testis, of course, ideally, I prefer the patients that never turn off the testis. That's why, the way I explain for the younger patients, for the parents, that I said, if you have a beautiful, expensive car at home that you don't drive every day, then we keep the testis starting every while for the day that they want to do it. That's the simple way that I approach these patients for many years before the time they have the partner. But for older one they come to me and they already had, testosterone treatment, which, we may see more and more often older people with Klinefelter under the testosterone because, 20 years ago, the Klinefelter were not under testosterone more than today, and then we had less issue. But it's still, if we prepare them, we have a good result. I mean, probably around the same number. Yes. Good question. Then the question will be, what do we do for people that they don't have a sperm? I mean, of course, when I don't find a sperm, it's a bad day for me because I tell them 70%, but I go for 100%. I want to be perfect, but the life is not perfect. And of course, the patient is not happy, but I'm not quite happy when we don't find it. That's why, as a scientist, we're trying to find options for this. Of course, the standard option is going through the donor sperm, embryo donation, adoption, which are options. And actually the process we do help them because that helps them to make a decision. A lot of people, they want to know that they tried everything possible and then they decide for a big decision, which is have an adoption, which is great. And personally, I love embryo donation because it's adoption on a very, very, early level. It's still the female partner can give birth to the baby, but that's an option. But of course, it's not the first option we want to have personally, or we don't sell anything, including this to the patients, but the patients prefer not. What can we do for this? That brought us to the new technology and the future, which my research lab is working on it. And it's not very fast going, but it's promising and very exciting. As I mentioned to you, a boy is born only with a spermatogonial stem cell, which is a stem cell for sperm. And then after puberty, this sperm production happens, inside the tubules, going all the way from spermatogonia to the full sperm. This is a study we actually did. This is a meta-analysis. We look at actually the published data from other groups to see what happened to the spermatogonial stem cell on Klinefelter patients over time. This is, at birth or even fetal, that, as you can see, 100% of the Klinefelter testis has the spermatogonial stem cell. And then when you go actually to the older age, the gray part become, happier and become larger. In a worse situation here, you can see that a little, more than half, they don't have the spermatogonial stem cell. But I told you, there's always limitation. This is based on some biopsy from some area of the testis. Nobody can remove the whole testis and look at it. Plus, the standard for all of these papers, most of them, not all of them, most of them is just a standard detection on a diagnostic pathology lab, which is a hematoxin and eosin without any specific marker. We actually perform a study in our group because we had a cohort of 100 adult testicular biopsy from Klinefelter patients. From the patient I was involved on their care for many years, and we use this cohort, and then we use a special, a staining, and we found that over 70% of them, even on an adult, regardless to have testosterone treatment or not, still they have the stem cells. Then what can we do with this? Because the number is quite low. It's increasing the number of this stem cell, and then, hopefully use that one to create more sperm. Because of this, we actually established a banking system in our institute, which is mainly for cancer patients, but we offer it for Klinefelter. We do not push the Klinefelter pediatric to go through this. Otherwise, they have another clinical surgery like a hernia or that they're going through that surgery, then we do the biopsy. I don't like to put the kids under the risk of anesthesia and another surgery if just for doing experimental stem cell, freezing. And we do it for before puberty, because after puberty, as data shows, they already lost a lot of stem cells. We have to wait until they want to have, their kids. We actually, based on this idea, we developed a culture system to increase the number of, the spermatogonial stem cell from Klinefelter, and you can see how it actually goes up. And we analyze which percentage of the cells that we grow are really stem cells. And we had a constant, number of those and enough for using for the future. Based on that, we put together these propagated cells and created a three-dimensional organoid system. And in that system that, we put the cells and they create, we create this organoid system after 48 hours. Then we have this structure of the organoids that we put them in an environment that we mimic the testis to push the spermatogonial stem cell through differentiation to the sperm-like cells. And as I showed you earlier this morning, we published that we could actually push them through that one. Of course, there are steps to have the full sperm and use this rounded spermatids to is experimental. But that's the future, and that's why we have this, clinical trial for, the using the rounded spermatid. Then in a few minutes that I have, I'm going to focus on the female part and the triple X. Do we have anybody interested on triple X in this room? But still, I think it's good to have it because I think we have around 100 people online. We may have there that they want to do it, or people in the future, they watch this presentation. The triple X, the good news is they don't have the same issue as or challenge that we have for, the XXY. The triple X also, described, initially on specific patients many years ago. And what they found that this, women are more at the risk of developing a pre-ovarian failure, which means they get to the menopause or lose the eggs faster than the others. That's the key for this. It's quite, common compared to many others, and a lot of them are fertile without any issue. That's the point. That's why, that nobody knows, and they can have kids without any issue. And it's quite common. And by chance, they found it in some, situation. But they have usually, normal puberty. But the main thing is the premature ovarian failure. What should we do for this? If we know and we have a young, triple X, we should recommend to actually be connected with the reproductive female specialist to watch their egg reservation and see if they need. It's very simple. There is a blood test that can screen the ovarian failure non-invasively. It's an anti-Mullerian hormone. And of course, there are more tools, but that's a screening and they can watch it. If it's dropping earlier than expected, they can think about freezing the eggs, which is possible, or even experimentally, which actually it's not anymore experimentally, freezing the part of the ovarian tissue for, future use. That's something that it's recommended on this because of the POF or premature ovarian failure, which, we see it in normal women too, without having this, but it's more common on triple X. And that's why, we have to do it. Then in summary, infertility is quite common. It's not only the problem that the Klinefelter or triple X are dealing with that. More than 98% of Klinefelters have really an infertility issue. Very, rarely they say they have child, which is possible because if they have a young partner, they have some sperm which are around 5 to 10% of Klinefelter draws. We can detect a sperm in their, semen. They can make somebody pregnant. And I never tell, and actually I tell the younger patients that be careful, even don't think that you're not able to make somebody pregnant. If you don't want to make pregnant, you started sex, be careful, because always, there is a chance that one sperm get one egg. We talk about the microscopic TESI and the way with the use of advanced IVF can help on this. And we talk about the spermatogonial stem cell technology and or organo system for the future. And we talk a little bit about the triple X, just I think the main message was the pre-ovarian failure and the way you can do it. Having this, I put at the slide, if you want to contact with me as a patient, these are the location and the phone number of the clinics that you can actually, contact. But you are very welcome to have my direct cell phone, and you can scan this barcode if you haven't done it this morning to get more information about our works.